Thank you so much. Well, thank you so much, Jill, for that powerful and impactful talk, and very inspirational. And thank you so much for all the work that you do and for the warm welcome to country. And I also would like to acknowledge the traditional owners of the land where we meet today. And thanks for Western Alliance and Drew and Sarah for the invitation to talk here today. I'm not sure if actually I've done it, so like I'm definitely trying to do it, but I'm hoping that, you know, today I can talk about how we trying to translate research into emergency care for back pain and other musculoskeletal conditions. And just to give you like an overview of the program of research that we're doing in Sydney and also in collaboration across New South Wales, that includes also regional and rural New South Wales. To give you an idea of how much back pain is common in emergency departments, every year the Australian Institute of Health and Welfare, they release an emergency department activity report that shows that back pain last year was the 5th most common condition presenting to our emergency departments in Australia. And it's been in the top 5 reasons for presentations to emergency for the last 20 years. In 2016, about 10 years now, our group, in collaboration with the New South Wales Ministry of Health, the Agency for Clinical Innovation, developed this model of care to manage acute back pain in the community, but also to provide recommendations for care in emergency settings. And it outlines 10 key principles of care, from assessment to timely referral to specialist care. But I just wanted to draw your attention to a couple of the principles of care, the ones highlighted in yellow, which is to provide people with back pain with simple analgesics to manage their pain and to avoid use of complex medications, including opioids, benzodiazepines, and gabapentinoids. But what we see is that a lot of opioids are prescribed for people with back pain. And this is overall opioid prescriptions that are dispensed in Australia. So 13 million opioid prescriptions are dispensed in Australia every year to about 3 million people. And there's research showing that about half of those is for people with back pain. And we have seen an increase in the number of unintentional overdose deaths in the last 20 years. And unfortunately, 3 people pass away every day from an unintentional overdose due to opioids in Australia. But when we did some research, our group has led some really large clinical trials, and one of them published in The Lancet was the OPAL trial that compared opioids versus placebo for acute low back pain and showed that opioids are actually no better than a placebo for managing acute back pain. One of the limitations that trial was done in primary care in the community. So like the role of opioids in managing acute back pain in emergency care is still under debate. So we still don't have that evidence coming from emergency care. But when we did some research in emergency departments to look at what happens to people after they are initiated on opioids in emergency departments and what happens after discharge. And these are opioid-naive patients, which means that they haven't taken opioids at all before presenting to emergency, or they haven't taken an opioid in the last 6 to 12 months before presenting to emergency. And what we did is we looked at what proportion of those patients that received an opioid in ED and how many of them continued opioid use after discharge. And we saw that amongst opioid-naive patients that received an opioid in emergency, about a third was still taking opioids after discharge at 3 months, and 1 in 10 was still taking opioids after 12 months. And this is to show you how much back pain is used to manage, how much opioids are used to manage back pain in emergency departments. And you can see that it varies from 40% to 85% of people presenting for back pain that receive an opioid in emergency departments. But 40 to 85% is a huge variation. And when we start seeing variation in care, we start thinking about potential for overtreatment and potentially low-value care. And you can see that the top 3 studies there are from Australia, showing that in Australia, we use a lot of opioids to manage people with back pain in emergency departments. And that brings us to the SHAPE trial, which stands for the Sydney Health Partners Emergency Department Trial. It was initially funded by Sydney Health Partners. And it was an implementation trial to try and address this issue of overuse, of overprescription of opioids for back pain in emergency care. It was a step-wedged cluster randomized trial, and it involved 4,625 patients. And we really developed implementation strategies to address the key barriers to adopting back pain guidelines and provide care according to the best evidence. The first one was education about back pain management, but also education about the potential benefits and harms of opioids in back pain management. And we trained about 300 emergency clinicians, and we developed a range of resources for both clinicians and patients. And also we had buy-in from executives, the chief executive of the local health district, emergency directors, senior emergency specialists. So really we had that buy-in from the leadership to do this implementation trial. The next strategy that we used was to provide emergency departments with non-opioid alternatives, because they were like, well, what else can we use to manage these patients? It's complex. And we understood that. So we formed a group of specialists, and we came up with a list of other medications that they could use instead of opioids. And also we provided and supplied each of the emergency departments with these Flexis heat wraps, which recommended by guidelines. Superficial heat is recommended in guidelines to manage back pain, and these are safe to use and keeps the patients mobile because they don't have to lie down on a bed to put the hot pack on. It's just like a wrap that's put around the back, and they can walk around and facilitates mobility. Patients loved it. The clinicians loved it so much that the heat wraps started to disappear from the emergency departments. So the clinicians and nurses and the doctors were using the heat packs. But it was a huge success. We also wanted to show our emergency clinicians their local data. They didn't really care about what was happening in the US or Canada. They wanted to know what's happening in my hospital. So we designed and we developed this dashboard that captured emergency department data for people presenting with back pain in near real time. And we sort of provided that feedback in a timely fashion to the specialists and also to the nurses. And when they had a look and we provided them with the numbers saying that, like 3/4 to 80% of people were getting opioids, they're like, wow, that's a lot. We agree that, we need to address as an issue. So it was a problem that was recognized by our clinicians and our health service as an important problem to address. And what we saw in the trial is that we saw a large and significant reduction in the opioid prescriptions. And when we look at sustainability, we saw that after 3 years after the implementation, we saw that the effects we saw 1 month after implementing the guidelines, the effects were sustained for over 3 years. And the doctors were concerned about patient-reported outcomes. So we also measured patient-reported outcomes, and we saw that there was no difference in patient-reported outcomes before and after implementation, showing that it's safe to use other approaches than opioids. And we also did a cost-effectiveness analysis looking from the hospital perspective that showed that the implementation strategy that we used is very likely to be cost-effective. We received quite a few questions about, well, if they're not using opioids, are you sure they're not using other risky medications? Maybe they've sort of started using other medications like benzodiazepines and gabapentinoids that are not recommended for back pain management. And then we did a secondary analysis that was published in JAMA Health Forum that showed that, in fact, we also managed to significantly decrease the proportion of people receiving benzodiazepines and gabapentinoids, and we significantly increased the proportion of people receiving the simple analgesics that are recommended in guidelines. So really, we saw a shift in practice from away from opioids to the simple analgesics that are recommended in guidelines for back pain. So we received quite a few recognitions in terms of NHMRC published a case study about the SHAPE trial on the website as a case study for research translation and other awards that Drew has mentioned as well. So it's a nice recognition of the work that we've done. So we got quite a few media attention with articles in Sydney Morning Herald, TV, radio, and also other online news outlets. And I guess most importantly is the impact. So the New South Wales Ministry of Health, the ACI, published our implementation guideline, our implementation manual, so other hospitals could also use the implementation strategies to adopt guidelines. The SHAPE trial was discussed for over 45 minutes in the New South Wales Special Commission of Inquiry into Healthcare Funding last year as an example of translational research. The findings from our trial were used to inform the development of the Australia's first national standards for low back pain that was published by the Australian Commission on Safety and Quality in Healthcare, that was published in 2022. And the implementation that we used has been adopted in 10 other hospitals across Australia, and some of those have also built in a research program to evaluate. And I've put a picture there of a couple of sites in Queensland that have not only adopted our implementation strategy, but also embedded a research program to evaluate it. And like Drew said, it led to additional funding from NHMRC and also from MRFF to do a lot more work in this space, not only in back pain, but also to make sure that we provide better care for other musculoskeletal conditions. One of the issues about the trial that we did in SHAPE was that it was quite complex, time-consuming, and resource-intensive. So it's really hard to scale up something that's quite time-consuming and resource-intensive. So we received funding from MRFF last year to do another trial across 44 emergency departments in New South Wales using this sequential multiple-assignment randomized trial that allow us to understand what are the optimal ingredients of implementation to make sure that our clinicians adopt best practice for back pain. So I won't go into the details of that. Another thing that I want to talk about is the guidelines. They are still recommending the use of opioids to manage back pain. So this is the guideline from the American College of Physicians. And here is the guidelines from the New South Wales Emergency Care Institute that recommends the use of opioids for managing back pain. And this is more recently a protocol it's a nurse-initiated protocol in New South Wales that allows nurses to initiate patients on oxycodone or fentanyl when they're presenting with moderate to severe back pain. So what we need is to generate robust evidence, and that's why we're doing a new trial. It's called ADAPTED. So it's being funded by MRFF, and it's really trying to look at the comparative effectiveness of different non-opioid medications versus an opioid using this adaptive trial design. Again, I won't go into the details of that. So now I want to talk about another program of research called Back at Home with RPA Virtual Hospital, now called Sydney Virtual Hospital. So it's Australia's first accredited virtual hospital in Sydney, and it was funded. The program of research was funded through HCF Research Foundation. So another issue that we found is that a lot of people with back pain, they also get admitted to hospital and they stay there for a long time. So there's about 177,000 hospitalizations for back pain in Australia at a rate of 690 per 100,000 population, which is a lot higher than other common hospital admissions, for example, for hip fracture, asthma, or heart failure. And when we look at the costs, 2/3 of the costs for managing back pain in Australia is coming from hospital care, so not primary care. And on the bottom here is a study that we did in New South Wales showing the huge variation in the admission rates across different hospitals. And again, when we see so much variation in care, we start thinking about over-treatment and overuse of resources. And that led us to write a paper to Lancet Rheumatology about whether back pain is a target for reducing hospital admissions. And the problem is that's not new. We've been talking about this for a long time, and this is a paper from 1990 where these people, which are the godfathers of back pain, have about the same topic, is saying should we really be admitting patients with back pain? Do we need to admit all of these people? And that a huge proportion, about 71% of them, have been deemed to be inappropriate admissions. And the other problem is that a lot of people are coming back to the hospital, to the ED, after they get discharged home from emergency departments for back pain. So we saw that about 8 to 15% represent within 12 months. And then when they come back, they're coming back because of unmanaged symptoms, because they didn't have the support to stay, to be managed in the community. It's not because they have something serious as the cause of the back pain. So that's another problem. It's the representations to emergency. The people just keep coming back to emergency because of the back problems. And that brings us to the Back at Home program, which is a new virtual hospital model of care that has been implemented in Sydney to provide care for people presenting to emergency, and the doctors and the nurses could refer them to this program to prevent a representation or to prevent a hospital admission for back pain. Again, it was an implementation study, so we engaged a lot with the clinicians and trained them on how to screen patients in terms of eligibility for the service, and also we embedded a referral pathway within the hospital systems and network referral forms and all that sort of stuff, and we trained them on how to refer patients. And this is just like a couple of quotes from patients saying, that I couldn't believe it. Like the next day after the hospital, a little lady came around and gave me some hit bags, and I thought that, wow, that's pretty amazing, that's pretty cool. And then like one day after I visited the emergency, the doctor called me just asking how my pain is. So like really providing that follow-up, which is important for back pain. And another quote is about, it was really good. I think the partner was knowing that I had the support. And a couple of times I called them in the middle of the night, saying, I don't know if I can go through this, which shows that it's really important to have that support to prevent that person from coming back to the emergency department. Again, a few more awards and recognition from this program. And very quickly, I just want to touch base on other two projects that are happening. So one is Reshaped, which is to implement or place physiotherapists, like really experienced physiotherapists in emergency departments to manage musculoskeletal conditions and free up doctors' time so they can see the more serious patients in a way to make sure that there's shorter waiting times and treatment times for these patients and better outcomes. And this is a randomized trial, and we have finished recruitment. We recruited 1,500 patients for this trial, and this is the second trial I want to talk about, which is RAINBOW. We love a nice acronym, and it's all about redesigning ambulance service to manage back pain, which is another problem that we saw, is that about 81% of people who are seen by paramedics are taken to hospital for back pain. So there's about 12,000 calls for back pain in New South Wales ambulance service, and so we want to provide a better support for paramedics and a new referral pathway. And we are just now working with the New South Wales ambulance service to implement a new referral pathway between the ambulance service and our back at home or our back pain program, the virtual back pain program, and we're trying to also embed a research program and randomized trial within that to understand the impact on the service and the health system. So really, to wrap up, I just wanted to say that the program of research that I'm presenting here today is based on a learning health system framework that we really use data to understand what's going on and to help us have discussions and make decisions, and also to embed a research program to evaluate and see how it's going. And if it doesn't work, we start again. We don't stop. And just coming back to what Drew said earlier is about funding, seed funding. When I finished my PhD in 2017, I received funding. I was supposed to go back to my home country after I finished my PhD, but then my boss gave me a job for 1 year using that grant. And then the year after, I got a fellowship from NHMRC, and then it sort of kept going. Like one thing led to another, and now it's a nearly 20 million research program that's funded by NHMRC, MRFF. So it's really amazing to see how initial funding from Sydney Health Partners really led to this amazing program of research that we're doing now. And just to acknowledge a lot of my collaborators, all these lovely people at NHMRC that pays my salary, but also the funders of the research. So thank you.